Good morning, everyone. Thank you so much for taking some time to join us today. We are here to do a couple of things. First, share the latest findings from a new report on the state of financial distress for California's hospitals. And then, more importantly, perhaps talk about how this financial distress is affecting people and patients in communities throughout the state. And we have four speakers today. The first is Boyle, President and CEO of the California Hospital Association. Carmela, please.
Thank you very much, David, and good morning, everyone. We know how busy you are. We appreciate you taking time to join us for this audio conference. We are here today, as David has said, to share some new and very difficult information about California's healthcare system. And it's information that really should be of concern to everyone in this state. And that is that California's healthcare system is really facing its greatest crisis in generations. What we're going to do today is make certain that you get a chance to hear from three hospital leaders who are on the front lines of healthcare, each in a different part of the state, each facing difficulties as a result of the current circumstance. But what I'd like to do is just to begin with a few key findings from the report before we talk about implications. So what I'd like to do with you today is to share four of the key findings out of the Kaufman-Hall report. The first is 20%. That's the percentage of California hospitals that are at risk of closure as determined by Kaufman-Hall. That means that we've got communities throughout the state of California who are served, basically 1 in 5 communities that could lose access to hospital care, emergency care, and all that goes with it. And just to repeat, 1 in 5 hospitals at risk of closure in California. I think we all understand what a devastating blow that would be to healthcare services, not just in those communities, but throughout the state. The second key finding, 52%. That's the percentage of California's about 400 hospitals, so that means more than 200 throughout the state, who are losing money every single day to care for the patients that they are treating. This is a significant challenge. This is the highest number of hospitals that are operating in the red, losing money every day caring for patients that we have seen in many, many, many years. So our challenges are the systemic underfunding by government payers, Medi-Cal at the state level, Medicare at the federal level. But that means for every dollar of care, hospitals are getting paid about 75 cents, and that is just an untenable situation. Third key finding, $23.4 billion. That is how much more it cost in 2022 alone to provide hospital care in California compared to pre-pandemic levels. Part of the challenge here is in addition to all of the losses incurred during the pandemic, we now are facing rates of inflation that are extraordinarily high. That means that it is very, very difficult as expenses rise and revenues remain relatively flat for California hospitals to continue to operate. So significant challenge there. And finally, fourth key finding, $8.5 billion. That is the number on top of the $12 billion in losses over the last 2 years. This is the third year of losses, meaning that California hospitals, even after federal COVID relief, have now lost over $20 billion in the last 3 years. And that just means that the healthcare math no longer adds up. So while those are four of the key findings out of the Kaufman-Hall study, of course, the real crisis and concern is what those numbers mean in every community across the state of California. And all of that is being borne by the communities and the people in those communities. Healthcare in those communities is eroding slowly in some places as we are losing certain services as hospitals try to make ends meet, whether that's closing obstetrical care, behavioral health services, or others. And in other communities, the services are being lost all at once. That is exactly what happened in one California community in California Central Valley, Madeira Hospital. Its closure at the very beginning of this year means that we have 150,000 people in that county without immediate access to care. They have to now go some 30 miles away to Fresno. But of course, we have to remember all of those for whom traveling 30 miles away is simply not possible. And that means healthcare services that are deferred and not received. So healthcare leaders are calling on the governor, on the legislature to act now before it is too late. We understand this is a difficult budget year for the state of California, the state looking at budget deficits. In March of this year, we had more than 350 hospitals and health system leaders who signed a letter to the governor and to legislative leadership attesting to how widespread this crisis is and our key ask, immediate financial relief to help hospitals remain operating and to keep those emergency departments and hospitals open. So today we just want to reiterate that call for help. The clock is ticking each and every day as the state moves toward conclusion of the budget process, likely in early June. But every single day that passes without action is a day that more and more hospitals in the state are taking the next step toward the edge of their survivability and toward the edge of access to care for their communities. So with that, what I'd like to do now is to turn it over in turn to each of three of our hospital leaders. In a moment, I'll turn it back to David Simon to introduce each one. We hope that they will help provide some examples of what's going on today in the communities that they serve as a result of this financial crisis. So with that, David, may I turn it back to you, please?
Yes, thank you so much, Carmela. And I'd like to introduce our first hospital leader here for today, Dr. Elaine Batchelor. She is the Chief Executive Officer of MLK Community Healthcare in Los Angeles, a member of the National Academy of Medicine. Prior to that, served as Chief Medical Officer of LA Care Health Plan, as Vice President at the California Healthcare Foundation, and as Medical Director for the Los Angeles County Office of Managed Care. Elaine, please.
Good morning, everyone. And I appreciate the opportunity to share a little bit about the challenges that we are facing in our community and in our health system. So I am the CEO of MLK Community Hospital and Healthcare. We are a small private community hospital and health system located in South Los Angeles. That means that we serve communities like Watts, Compton, Linwood, Inglewood, among other communities. These are communities that are almost entirely low-income people who are Black and brown and are insured through Medicaid and to some degree through Medicare. There's very little private commercial insurance in our patient base. Even before COVID, our community was severely medically underserved, and we operated one of the few care delivery sites in the community. We operated one of the busiest emergency departments in the county because of the lack of access to medical care in the surrounding community. And our community lacks 1,500 providers, 1,500 doctors, compared to other communities and standards for access to primary care and specialty care. During the COVID pandemic, our community was among the hardest hit in the state. Our small community hospital took care of more COVID patients per bed than large tertiary medical centers. The high volumes of patients that we're caring for have persisted even though the COVID pandemic is now over. The number of patients that we're seeing in our emergency department is higher than ever. We are on track to serve about 115,000 visits annually in our emergency department, and our hospital is more than full. It's a small hospital, and we are now running 20 to 40 to 50% above the number of licensed beds in the hospital. And this is not being driven by COVID. It's being driven by the baseline unmet medical needs in our community. Those unmet medical needs are related to the fact that our community is low income and dependent on Medicaid and Medicare for insurance. Medicaid pays pennies on the dollar for medical care, and as a result, providers can't afford to practice in our community, and the result is that our community lacks access to doctors. So our hospital is taking care of patients with very basic untreated medical conditions like diabetes, high blood pressure, heart disease, and kidney disease. As a result of the pandemic and the inflation that has followed the pandemic, we are now losing money. The high volume has driven a need to use temporary nursing labor, which is very expensive, and high cost for supplies and equipment. Public payments don't increase as fast as our costs have been increasing, so we are now losing money. We began to lose money in 2021, and we are continuing to lose money. We are now using our reserves, and we are seeking to borrow to help continue covering our costs, but eventually we won't be able to cover our costs through those sources. The impact on our patients when we need to begin reducing services and cutting back is going to be devastating. They are already medically underserved, and they don't have other places to go in the community to seek care. Losing services like labor and delivery, behavioral health care, and disease management will be devastating for a community that is already suffering from significant health disparities. One example is just a wound care center, which we opened in our community, the first wound care center ever open and available to people living in South Los Angeles, where we are providing care for patients with diabetics, which is something that's epidemic in our community, and preventing diabetic amputations, which are the #1 surgical procedures in our hospital. We could be forced to close that wound care center. We could be forced to cut back on maternal care. In fact, we could be forced to close our labor and delivery service. We know that women in our community are already lacking prenatal care and a safe place to deliver babies. That would be devastating for our community. These are some of the things that we're worried about, and we're really hoping that people in our state will pay attention to the crisis in our hospitals and that our legislators will step up with assistance. So I'll stop there and allow someone else to take a turn.
Thank you so much, Elaine. Let's go now, please, to Donna Hefner. Donna is a registered nurse. She has served as president and CEO of Sierra View Medical Center since 2013. Prior to that, holding several senior leadership roles, laboratory, pharmacy, respiratory services, employee safety, patient care. Donna, please.
Thank you, David. And good morning. Thank you for this opportunity to share our story. Sierra View Medical Center has been open and operating acute care services for 65 years. We are an independent district hospital located in Portland, California. It provides, as I mentioned, acute care and outpatient services to a community of a immediate residents of 62,000. Our immediate service area, but we serve a greater service area, which is a region that spans a population of 115,000. Geographically, you can imagine that span is over 60 miles. So we are located in the foothills of the southeastern region of Tulare County. Our nearest trauma hospital is over 45 miles away from Sierra View. The region is heavily agricultural based. Its dominated area provides the nutritional food for many people in the United States, heavily agriculture based. Sierra View offers 167 licensed acute care beds for inpatient and short stays, and we also are home to 35 residents that live in our distinct part skilled nursing facility. The hospital provides emergency services to over 40,000 people in an 18-bed ER. We have a wider range of services that covers all ages from birth to geriatrics, and those services include intensive care, labor and delivery, the medical surgical. We have a wider range of surgical services, as well as very comprehensive imaging modalities. And I'd also mention that in our services, we have, prior to the pandemic, we're growing services such as wound care. We have a high population of people with diabetes, as well as cardiac disease. So we also have opened services for outpatient physical therapy and a cardiac cath services for those high prevalence diseases. So we supported care over the last year for 22,000 patients, inpatient totals. We discharge over 5,000 patients annually, and those services, are a wide range. I share with you this today because we are in an area that is very medically underserved, as well as we serve in a health provider shortage area. So it's very difficult to attract highly skilled providers, as well as physicians and trained licensed staff to our area. So we count on and having our acute care hospital for those needs. Some of the challenges I can tell you, being with the organization for many, many years, we've always served in an area that was a challenging payer mix. In looking back in 2007, at that time, 38% were insured by Medi-Cal. As of February, over 46% of those we cared for were insured by Medi-Cal. 80% of our patient revenue comes from governmental payers such as Medicare and Medi-Cal, and so these reimbursement programs they don't even cover our cost. So that is critical. Over the last few years, we've been seeing what's been impacting these losses that we've experienced in the last 2 fiscal years. It's really the exacerbation of the market forces, such as inflation, staff shortages, supply chain disruption, and pharmaceuticals. And I'll underscore that the revenue is not keeping up with these costs. I say it's fixed revenue on a free market cost. And so over time, this has really caused us to have to look at those services, and we are also evaluating no longer growing services, but actually looking at what we can do to preserve the emergency and acute care services that we offer to our community, which would result in scaling back some of those much-needed outpatient services. So with that, I will go ahead and turn it back over to the moderator, David. Thank you.
Thank you so much, Donna. We will now go to our final speaker before we go back to Carmela for some closing remarks and then questions from the media. Our final speaker today, Patty Mason, is Chief Executive Officer of UC San Diego Health. That is the San Diego region's only academic health system, includes UC San Diego Medical Center, Jacobs Medical Center, several other specialty medical centers and institutes. Patty, please.
Great. Thanks so much, David, and thanks for calling into the update. So I'm going to talk about kind of 2 different situations. First, focusing on San Diego and my own health system. We are in the process of trying to replace the Hillcrest Hospital. We took that hospital from the county in the late 1960s and started operating it, and it is really the functioning county hospital. We have trauma, burn, HIV care, a lot of services for our communities that have poor access to care. And so the process of trying to replace a hospital in California is extraordinarily expensive. We are estimating right now it'll be probably a $2 billion replacement, which will require, a lot of access to capital and to debt financing. Because it's fundamentally a replacement versus a new hospital with new revenues, it's very hard to sustain a debt structure of $2 billion new debt when you're operating P&Ls and operating margins are so challenged. And I won't reiterate what the other two speakers have said, but the pressures on our margins right now are extraordinary. I've been in healthcare in Southern California for 35 years. This is the hardest it's ever been. I'll just frame it that way. Trying to maintain a margin, trying to break even in a situation where contract labor is extraordinary. Labor expenses are inflating well above any of the kinds of increases that we might see from the payers. And then to have the government payers basically be flat or less, it's an unsustainable situation. So, we're working all of those variables and trying to find a sustainable path, but some relief with respect to improved reimbursement is hugely important, particularly for our Medicaid population that we're so committed to caring for. We're also involved in Imperial Valley. Imperial Valley is the poorest county in the state. It was probably the hardest hit county from a COVID perspective. I'm sure everyone remembers the stories that came out of Imperial Valley, El Centro Regional Medical Center, and Pioneers Memorial Hospital during COVID. It's been a very, very difficult period for them as they've rolled out of the pandemic. They are very, very challenged and really, I think, months from running out of cash. We have, since we've had a long-standing relationship with El Centro Regional Medical Center, we've been there trying to support that community for the last almost 8 years. We've stepped in to try to operate the El Centro Regional Medical Center operations and see what kind of improvements we can drive. But there's under no scenario is there enough levers to pull to make that hospital sustainable long-term in its own accord based on the current economic environment. The two hospitals out there need to come together. They need to find cost economies. They need to find scale for clinical program growth. They need relief for debt. They need support for reimbursement. All of those things need to come together in order to create a sustainable health system in Imperial Valley. The thought of those two hospitals not being able to function long term and the impact to that really quite sizable population base is devastating. We really can't let that happen. And the state has been engaged, and we're working hard to try to come up with solutions. So we're grateful for that. But just to say, this is just one scenario. Carmela can talk about multiple scenarios across the state where hospitals are within 2, 3, 4 months of running out of cash. And they're going to close without some kind of major intervention. David, back to you.
Great, thank you. Thank you. And David, I'll just jump in here to close quickly before we go to members of the media for their questions. First of all, thanks to our speakers. For members of the media, I hope that you can appreciate how difficult it is for these leaders and leaders across the state to talk about the financial challenges they face. These are very sensitive situations and sensitive in that it is important that we continue to be able to keep staff and clinicians and others working within these communities. So we appreciate your understanding of that. Second, we'd just like to indicate, as you can hear, this is a challenge throughout the state. There is quite a focus, and it's an important focus on what's happening in some of our rural and isolated communities. As you can hear today, this is a problem in both rural and urban communities, small and large communities, among independent hospitals and hospitals that are part of systems for not-for-profit hospitals and investor-owned hospitals. This is widespread, and it's because the fundamental problem here is systemic. It is driven by underfunding for government health care programs on the part of the state and the federal government, Medi-Cal and Medicare. Expenses are simply outpacing those government payments. the only fix here and the only sustainable fix is an increase in those reimbursement rates. I know there will be much conversation about short-term immediate solutions. We are looking at an immediate request for $1.5 billion from the governor and the legislature to tide hospitals over and prevent any more hospital closures in the state of California. And back to today's study in the release, 20% of California hospitals are currently at risk of closure. So with that, David, let me turn it back to you, please, to field questions from the media.
Thank you so much, Carmela. Thank you to all our speakers. Shana, we will now open the call to questions from members of the media. Thank you.
Certainly. We will now allow questions from the phone lines. Ladies and gentlemen, to ask a question, please press star followed by 1. To remove that question, press star followed by 2. If you're using a speakerphone, please pick up the handset before using the keypad. Again, to ask a question from the phone lines, press star followed by 1. Our first question comes from the line of Rachel Bluth with Politico. You may proceed.
Hi there. Thanks for having this press conference today. I just wanted to be clear on what the ask was here. There's been a lot of advocacy about that $1.5 billion, and also asking for increased Medicaid reimbursement. Have you thought about? So I want to make sure that's right, and increased rates. And I want to be clear: is this money that you hope to come from the new MCO tax, or do you have, other ideas about where some of this money might come from? So that's kind of my first question. And my second is, Camilla, you just mentioned that we need to do whatever we can to keep staff and clinicians and others working in these communities. I'm actually right outside a health hearing, or a legislative hearing right now, where they're going to talk about a $25 minimum wage for healthcare workers. So is that part of that? Can hospitals afford to do that right now? So if I get answers to both of those, thank you so much.
Sure. Thank you very much for those questions, and thank you for being at today's hearing. First of all, you asked about a connection to the Managed Care Organization, or MCO tax. I think our message today is that California's hospitals are at their most vulnerable position in a lifetime. The most vulnerable, certainly I've been doing this for 35 years, the most vulnerable that I've seen it. The decision in terms of how the legislature or this administration might ultimately fund any kind of financial relief is really up to the legislature and to the governor. Whether that is using an MCO tax, rainy day fund, whatever that might be, that's really their decision, and it's really their authority. What we're saying is that California is better than this. As goes California, so goes the nation, and we cannot allow one more hospital in the state of California to close. So revenue sources, we are happy to have that conversation, but that is really up to the legislature and to the governor. To your second question about a $25 minimum wage, as you are aware, there is a hearing today on that piece of legislation. It would be a $25 minimum wage that applies to all of healthcare, and not just healthcare workers, but healthcare contractors as well, and also includes workers who are not necessarily employed by the hospital, but are doing work on the premises of a hospital, maintenance, repair workers, transportation workers, and others. What that is an example of the continued and relentless pressure on healthcare, and in particular California's hospitals. If today's study demonstrates very clearly that expenses are outpacing revenues and hospital leaders cannot make ends meet, adding an expense like a $25 minimum wage takes that very serious problem and makes it impossible. So the challenge that we have here is we've got a healthcare system at risk. We've got expenses that are far outpacing revenues. Anything we do at this moment to add additional cost, and certainly in the absence of any change in the revenue stream, is dangerous. And it's something that absolutely has to be avoided. Thank you for your question.
Thanks.
Thank you. Our next question comes from the line of Kathy Anderson with the Sacramento Bee. You may proceed.
And super. I was going to ask if we could ask our Politico reporter to mute her phone. Thanks. Go ahead.
Hi. Thanks for taking my question. I have actually a few questions. One of those is simply a numbers question. That is, Dr. Mason and Dr. Batchelor both mentioned, Ms. Hefner, both mentioned annual visits or measures of visits at their facilities. And so I'm wondering whether they can tell me pre-COVID what those visits were like. My next question is, are you at all concerned about flight of physicians who are worried that maybe a hospital won't be sustainable and so they won't have opportunities there in future? And then can Dr. Batchelor and Ms. Hefner talk about, Dr. Batchelor and Dr. Mason, can they talk about, or Ms. Mason, can they talk about access to other hospitals for their patients? Do their patients have access to other hospitals that is comparable to the access they have for their hospitals? Thank you.
Thank you so much. And why don't we field it this way? If I could ask Donna Hefner to please go first, talk a little bit about visits and volume pre-pandemic and what you're seeing now, and the question about physician flight. Then I'll turn it to Dr. Batchelor to answer both of those questions, as well as what does access look like to other hospitals, and then we'll close out, please, with Patty Mason. Donna, if we could start with you first, please. Talk a little bit about visits pre-pandemic, post-pandemic, and concerns about physician or clinician flight.
Sure. Thank you, Carmela. So in regards to pre-pandemic, we were seeing an average of around 30 to 32,000 visits in our emergency department, comparative to over the annualized estimate for this year of 40,000. So a significant increase in our emergency care visits, as well as our patient days. Obviously, we were during pre-pandemic, we are pretty aligned on our patient days and patient discharges there. But again, the complexity of the patients in which we're treating today comparative to pre-pandemic is very much more complex. And so we have been seeing that in our daily assignment of staff based on the complexity of the patient care. So we have seen an increase in the emergency room with volume, and in regards to physician flight, we have been in a health provider shortage area for many, many years. And as our community physicians are getting up in the years of looking at retirement, the model in which patients are able to access primary care has become very challenging. So again, that could be, how they access care is usually through a federally qualified health clinic or a rural health clinic, and a few of our community-based clinic physicians. So it is getting difficult to provide that access to care in a primary care space. So
thank you, Donna. Elaine, please, on visits pre and post. I think, as everyone knows, this is not just about COVID, and then concerns about clinician flight.
Sure, thank you. So even before COVID, we were a very busy hospital because we are one of the few care delivery sites in our community. So prior to COVID, we were seeing about 100 to 110,000 visits per year in our 29-bed emergency department, and 80 to 90% of our inpatient beds were occupied. Now we are seeing 110 to over 115,000 visits a year in our emergency department. And as I mentioned earlier, 120 to 140% of our beds are occupied. With regard to physicians, the first thing to note is that we have to subsidize every physician who works or sees patients in our hospital, meaning we have to pay them above what Medicaid pays, because physicians will not work for that rate. So they are in our hospital taking care of our patients because we are subsidizing them and paying them market rates to take care of patients. And as long as we are able to pay them, they will come and take care of our patients. When we are not able to pay them, we will no longer have physicians to care for our patients. In the surrounding community, there is a marked absence of physicians because physicians can't support a practice on what Medicaid pays. And we are also seeing, some of the few physicians that actually have practiced in the community are retiring. They're aging out of medicine, they're retiring, and we're not seeing new physicians entering the community. So the physician deficit in our community is actually getting worse over time. Thank you.
Thank you. And Elaine, if you would then transition to the question about would there be access to other hospital care? I know your community is very unique. Would there be access to other hospital care?
Mm-hmm. Our community is located in an area of the county that has the smallest number of hospital beds per 100,000 people. So there are not very many hospital beds at all in this community. We also know that people in our community lack transportation, so it's not a simple matter of just getting in your car and driving somewhere else. They are not able to do that. And the last thing I would note is that other hospitals don't want to take care of our patients, and that's because they are insured by public payers, primarily Medicaid. So, our experience is when we have a patient who needs a higher level of care than our small community hospital can provide, we struggle. We spend days trying to find other hospitals willing to accept that patient who needs medical care that we can't provide. So, the idea that our patients are simply going to go to some other hospital is just not feasible at all.
Thank you. And Patty, if you could close us out, please, perhaps from the perspective of what happens in Imperial County if the hospitals are no longer available, and implications for the county over San Diego.
Of course, and if you don't mind, Carmel, I might just make a little bit of nuance on the other two questions with respect to visits and volumes. Just with respect to UC San Diego as an example, we've had unprecedented growth in our emergency departments, and there's not a day that goes by that we don't have anywhere from 40 to 100 patients waiting for inpatient beds that we don't have right now because we're full. And so the demand has been high. I think the emergency department volume itself is up 7%. So that doesn't tell the whole story. As everyone has said, the patients are sicker. So the number of patients coming in that then need to be admitted, that percent has gone up. The age of the patients coming in through our emergency department has gone up. So the complexity, age is driving greater admissions of these patients, and there's simply not capacity to take them in. So we have to hold them until we can get beds available. So it's a day-to-day struggle for patient flow. With respect to physician flight, that I'll put more in the context of El Central. I will say for UC San Diego, in San Diego, as Elaine has said, we subsidize our physician compensation almost $100 million a year so that they can be paid market rates, which makes up that difference of the government payers who are paying less than market, right? So that's a huge demand on our cash to be able to support those physician salaries. And unless I can keep the margins at a reasonable level, that's hard to sustain. So we will have physician flight if that takes place. In El Centro, in Imperial Valley, it's always been a struggle to get physicians there. And back to what is the long-term sustainable plan for Imperial Valley? The idea of having the community come together around a single health system will create some ability to have enough volume and enough scale, I think, to do some recruiting of new physicians that aren't there today. And I think that will help that valley quite a bit. But right now, it's so hard to recruit a physician to go serve out there full time. And if those two hospitals close, to be clear, it's a 2.5-hour drive to San Diego. It's a 2-hour drive to Palm Desert. It's, a 2-hour drive to Arizona. That's why it's so critical that we keep a health system open in Imperial Valley, because there really isn't good access. And, anything that's emergent or urgent will be at jeopardy if we don't have hospitals there.
Thank you.
Thank you.
May I beg my peers' indulgence and ask you, Carmela, is there anything that prohibits paying a higher Medi-Cal rate to providers who have a higher percentage of Medi-Cal patients?
There is, the only limit, I think, to improving Medi-Cal reimbursement rates are budget challenges on the part of the state. I think we feel strongly, you can hear us, right? We feel strongly understanding the state's budget challenges is important. On the other hand, serious problems don't go away simply because there are budget problems. This must be a priority of the state of California. An additional hospital closure is simply not something that is sustainable, and you can hear it's not as if those patients can go someplace else. This is quite serious. Redistributing how those dollars are paid, much more difficult. What we are asking for in the immediate financial relief that we have requested of this administration and this legislature is to distribute those dollars based on the Medi-Cal population served. So in terms of the immediate financial relief, not Medi-Cal rates, but immediate cash to keep hospitals' doors open, to keep emergency departments from closing, those could be allocated in such a manner.
Thank you.
Thanks. Other questions, Shana?
Thank you. Our next question comes from the line of Emily Hoven with San Francisco Chronicle. You may proceed.
Hi. Thank you so much for taking my question. I also wanted to better understand, I know you mentioned that you are seeking $1.5 billion in temporary relief from the state. But in terms of changing the Medi-Cal reimbursement rates or changing it on the federal level, I mean, what exactly would have to happen for that to go into effect, and how significant of a rate increase are you talking about? And yeah, kind of what would that process look like? Who's in charge of it? Which lawmakers have maybe expressed an interest in that? We'd just love to hear more about the process in Sacramento.
Sure. Let me start by putting that $1.5 billion into context. It sounds like a lot. It is about 1% of California's Medi-Cal budget. So in context, it is a relatively small amount in terms of what we currently spend on the Medi-Cal program. It is desperately needed. It is far less expensive for us as a state to keep hospitals operating than it is to allow a hospital to close and try to bring that hospital back. So that's the first piece. The second, in terms of what it would take to increase Medi-Cal rates, and by the way, Medi-Cal rates for hospitals have not been increased in a decade. So what's needed is legislative action and obviously a means of financing that change. but the time has come. We knew COVID was very, very challenging for California's hospitals. We asked for help and relief at that time. There was none that was provided by the state to the field as a whole. And now all of that is coming home to roost, as described in this Kaufman Hall report, where we now have California hospital losses after federal COVID relief topping $20 billion. So it's a matter for the legislature, could be done as part of the state budget discussion, legislative discussions. Those rates simply need to be adjusted upwards.
Quick follow-up. If there isn't legislative action, is there a way that hospitals could address this, maybe through a ballot measure? Are there measures you would support to kind of change those rates, since there hasn't been action, it sounds like, in at least a decade?
And I think what you're talking about is sort of through what avenue can we ultimately try to achieve better Medi-Cal reimbursement, and please don't forget Medicare reimbursement as well. We're having these very same discussions in Washington, D.C. with our California congressional delegation and others. I think from our perspective, the approach is less important than the outcome, what we need. And this immediate financial relief, the $1.5 billion, is simply state general funds. That is not about Medi-Cal rate increases. However, anything we do in the short term is just that. It is short term. It is putting a finger, in the hole in the dike. What we need is a long-term sustainable solution, and that is a Medi-Cal rate increase, which could be achieved by this administration, this legislature, in any number of ways. Thank you.
Thank you. Our next question comes from the line of Howard Fine with Los Angeles Business Journal. You may proceed.
Yes, thank you. 3 questions. One for Elaine Batchelor on, you mentioned reserves, and you're tapping the hospital reserves. And so how much do you have in reserve? How fast are you burning through the reserve? And then this would also apply statewide if there are any figures to bear that out. Also, you mentioned the cost of borrowing. Hospitals are having to borrow to sort of paper things over right now with this cost imbalance. Well, there are much higher interest rates now, so what is that doing to the ability to borrow? And the final question is on seismic retrofit mandates that many hospitals face and have yet to fully finance. What does operating in the red for so many of these hospitals mean for trying to address those seismic retrofit mandates?
Thank you. And Elaine, if you'd like to jump in on reserves and cost of borrowing, I'd be happy then to talk from a state perspective. And just for our media colleagues on the phone, wanted to let folks know that Patty Mason did have to drop off our call. Elaine, if you'd like to start with his question about reserves.
Yes. So, the length of time one's reserves will last really depends on what you continue to operate. So, we will try to maintain core services in the hospital, the emergency department and inpatient services, for as long as possible. But that will mean cutting back on other services. So it could mean it could mean closing labor and delivery. It could mean eliminating services for people with mental illnesses. It could mean eliminating our community disease management programs. So it's not easy to answer that question. It really depends on what we begin to cut back. And we are at a point now where we are having to consider and think about which services to cut back so that we can preserve our limited dollars for as long as possible. We are, our financial situation is such that we are not really credit worthy. So we can't go out onto the market and borrow money because we just aren't financially strong enough to do that.
Thank you. And if I may just comment from a statewide perspective, you asked about whether we had statewide data. The data that is out there and available is quite old. You can hear this is a situation in flux. The issue of days cash on hand is the immediate crisis, the immediate challenge that hospital leaders across the state are facing. They had to dip into those reserves to continue to function during the pandemic to offset now these high inflation costs. And I think Dr. Batchelor has described well the implications. On the cost of borrowing, I think it's very important to remember, as you've heard Dr. Batchelor say, for a number of our hospitals, borrowing on the open market is simply not possible. Most of the large financial organizations, Moody's, Fitch, those who determine the creditworthiness of hospitals, have hospitals on a negative watch, and that is because of our financial challenges. So we have this chicken and egg problem. But I also want to flag for everybody that the cost of borrowing is only an issue if borrowing is an option. And what I mean by that, it only makes sense to borrow if an organization believes that they can pay that money back. And the fundamental challenge we have with many organizations, because the math doesn't add up, that borrowing simply kicks this liability can down the road. And so absent this underlying change that needs to happen in terms of Medi-Cal rate increases, absent the math adding up, taking out a loan, regardless of the cost of that loan, is quite financially risky. And finally, on seismic, and this connects back to the question on the current proposal for a $25 minimum wage. The cost of seismic compliance in the state of California is extraordinary, well over $100 billion between now and 2023. Even if we had all the people who were able to do that work, it is another pressure on the expense side without any change on the revenue side, making this circumstance impossible. Thank you for the question.
Just to clarify, you said well over 125 billion, and then you said something about in 2023. So it's between now and what?
I said well over 100 billion between now and 2030. So today, hospitals are seismically compliant with the 2020 standard. That was ensuring that buildings will not collapse. The 2030 standard that hospitals are now trying to work toward is not about safety. It is about whether a hospital is fully operational after a seismic event, after an earthquake. That is now what hospitals are attempting to run toward. That will be a cost of over $100 billion. That work is supposed to be complete by 2030. And as you might imagine, that just becomes not just another stressor, but as I mentioned, a near impossibility against this environment of 1 in 5 hospitals at risk of closure today.
Thank you. Again, ladies and gentlemen, to ask a question from the phone lines, please press star followed by 1. We will pause here briefly to allow questions to generate in queue.
And I know we've only got a couple of minutes left.
Yep, looks like we have one more. Shayna, if we could make this our last question, please.
Hello?
Emily,
I'm sorry, I'm sorry, I was on mute. Our last question comes from the line of Emily Hoban with San Francisco Chronicles. You may proceed.
Sorry for the repeat question. I just saw a press release about this, so I wanted to ask. So I know that some Republicans in the legislature are also saying that some of the Attorney General's denial of certain hospital mergers has also been contributing to the crisis of hospital closures, and I'm curious if this is also the perspective of the Hospital Association as well.
Thank you for the question, Emily. I think there are two issues related to actions taken by the Attorney General. Well, two issues related, let me say, to merger acquisition affiliation. The first challenge is that California has been a state in which, in the past, if a hospital was financially challenged, a hospital near closure, it was a situation in which some of our larger health systems in the state were able to step in and rescue, if you will, that hospital organization. Unfortunately, as we mentioned earlier, this financial crisis is affecting everyone, and it has considerably limited the ability of other hospitals to step in to rescue or save hospitals that are going under. The second challenge as it relates to affiliations, ways in which we could prevent hospitals from going under, does lie with the Attorney General. I think the conditions that this Attorney General has placed on hospital mergers, acquisitions, and other kinds of affiliations have been conditions that simply cannot be met in this financial environment. I know the Attorney General has expressed, and the Attorney General's team has expressed their desire to ensure consumer protection. And of course, consumer protection is very important. However, what we are not doing is thinking about consumer protection. Which consumers are protected when their local hospital closes, as happened in Madera County? Those consumers are not protected. They don't have access to the emergency care and acute care services they need. So we would strongly encourage the Attorney General and the Attorney General's team to rethink what were perhaps criteria that may have made some sense in the past, what those criteria need to look like in a very desperate financial situation where the very definition of consumer protection is ensuring that people have a place nearby to go for an emergency, to have a baby, and all the rest.
Thank you so much,
Carmela.
And just to clarify, are those conditions that he is applying, have those been the case in the past, or is it kind of a new standard that he started using when he took office?
I'm probably not the best person to answer that question. I think in general there have been concerns that when organizations merge, that it has the potential of increasing the price of health care in a particular market. That cannot be the only set of criteria that we're looking at in a very different environment, where this environment is about preventing hospital closures. And so one of the things we all have to understand is that if the math isn't adding up for a hospital and it's leading to closure, the math isn't going to add up for anyone else who might step in to be helpful to that hospital as well.
Thank you, Carmela. Thank you, Emily. Thank you to all who were able to join today's call and all who were able to ask questions of our speakers. For those who have more questions, you can reach me, dsimon@calhospital.org. This concludes our call for today.